Okay, thank you everyone for joining us today for the last autumn quarter Michael M. Davis lecture. We'll resume the next lecture series in winter 2021 and look for our lineup on the CHAZ website early December for probably a January start. In a moment, CHAZ co-director and SSA professor Harold Pollack will offer brief remarks and introduce today's presenter, research professor at the Harris School of Public Policy and research associate of the National Bureau of Economic Research, Robert Kaestner. We will allow questions in the Zoom Q&A pane as well as the chat function. If anyone has questions as Bob is presenting, we welcome answering those calls and fielding discussions. A copy of today's PowerPoint will be archived on the CHAZ website, and a recording from today will be posted on the CHAZ YouTube channel. And now Harold Pollack will introduce today's speaker.
Thank you. It's so great to introduce Bob today. Bob is one of the health economists I just very much most admire. We've known each other for a long time, and I think we first were introduced because Bob emailed me about a fairly prominent paper in health economics and said, well, let's think about what we'd have to believe that the results in this article are true. And for the population at the margin, we'd have to basically, there would have to be an implausibly large effect. And he brings a sense of realism to a field where often people try to defend implausible results by pointing to sort of, we didn't do anything wrong in the methodology. And Bob is like, wait a minute, let's just bring a real world reality check. A few things about him. He's published, I believe, 125 articles in the peer review literature, and among economists, that's quite an amazing number. And when I was just looking at his Google Scholar page, the range of things is quite striking. Among his most widely cited papers, the effect of education on health, but also consumer financial literacy and the impact of online banking on the financial behavior of low-income banking consumers, the impact of malpractice fears on cesarean sections, the impact of pregnancy and tension on child development with Ted Joyce and Cindy Kornman. Just a remarkable range of things at the intersection of health, public policy. They're really important contributions. And I should also note, Bob has a connection to SSA, that he actually won the 2012 Frank Briel Memorial Prize for the best publication in social service review. And I'm just really looking forward to learning from you today. And with that, I'll let you take it away. I will be monitoring the chat for Q&A because Bob's ready to field questions and so on in the true University of Chicago manner. So thank you for talking, and I'll stop talking now.
Well, thanks, Harold, very much for having me. So with some of those accolades, really what Harold is saying is that I'm old. So from there we'll go on. But this is so today I'm going to talk about the effects of the minimum wage on child health. It's joint work with my former student, Daval Dave, Wei Liu, and George Webby from the University of Iowa. It's been partly funded by the Robert Wood Johnson Foundation. So, and I'm really happy. And as I said, I'm happy to take questions as we go along. Harold can interrupt me, and I'm fine with that. So, what's the motivation for this? That the minimum wage affects labor markets. This is what's dominated the debate over the minimum wage. Does it decrease employment, increase employment? And that's been a long-standing, maybe ad nauseum debate in the United States for a long time. But what we do know is that the minimum wage does increase the wages of low-skilled workers. It may have some small to no effect on employment. So overall, we expect the minimum wage to increase income for low-skilled workers. All right. And then, so those income and employment effects can affect child health. Right? So greater income, for example, we can increase investments in child health and improve child health that way. There might be some effects of employment. If you're working more or less, you might be able to spend less time investing in your child's health in certain ways. So, so this is what we call in economics, we'd say that's the first stage. Minimum wage affects labor markets. The second stage is the income or labor market affect child health. And then we could do the reduced form, which was what I'm going to focus on today, is what is the direct effect of the minimum wage on child health. And those mechanisms have been outlined above. Through higher income, through greater investment, and perhaps because of some changes in time investments. So the contributions of this paper, again, the most important one is it's the first study of the effect of the minimum wage on child health. And again, I think it moves past the debate and the narrow focus of the effects of the minimum wage that just focus on employment and does it increase or decrease employment. So we can think that the minimum wage would have effects on lots of different domains besides just child health. And at the end of the lecture, if I have some time, I'll show you another analysis we're doing on the effect of the minimum wage on children's test scores and educational achievement. Then the other thing we do is we focus and show that how does the minimum wage affect child health during early and later childhood periods. So remember, the minimum wage child of age 8 or 12 or 15 has been exposed to different minimum wages throughout their lifetime. And we try to identify whether being exposed early in your life or later in your life has differential effects. And then I think another important contribution is to the effects, to the literature on the effects of income on child health. Now, I was surprised, everybody believes that income affects children's health. And a lot of what social scientists do is try to, show the obvious, but there really hasn't been that many studies of this issue. And as you'll see here, the evidence is really very mixed. And almost all of the evidence on the effect of income, or the quasi-experimental or experimental evidence on the effect of income on child health, really pertains to birth weight and height and weight. There's very few other aspects of health that have been examined. So we contribute because we have an exogenous or plausibly exogenous change in minimum wages that affects income, and that income will affect child health. So we add to this literature in that way. So, I think, Keith and Harold told me there's students here and for graduate students, but your first inclination is let's just run a regression. Let's have child health, some measure of child health, and regress it on the minimum wage. But it helps to really take a step back and think about that for a little while. So we're going to spend a couple of slides, maybe boring slides, on a conceptual model. But that conceptual model it's not a behavioral model. It's really what we call a production function, and it's pretty simple in that it just says that health at age 7 depends on your health at your starting age that you were born with, and then your investments at each age. Investments are denoted by I, and then investments in health throughout your lifetime, right? So, for example, when you're age 0 or in the first year of life, there's some investments in your health. Those investments have some productivity of those investments, and the quantity of investments, and that will increase your health. And then over time, that health will depreciate, and that's the depreciation aspect, and that health will depreciate. So the idea is your health at any age depends on your initial health, and then how does your health evolve through investment and depreciation. Where does the minimum wage fit in? The minimum wage raises income, or that's how we're going to talk about it mostly today. And this increase in income will increase investments. So you can see that at every age, at age 0, the minimum wage will affect the investments. At age 6, the minimum wage at age 6 will affect the investment. So over the course of someone's life, what's the effect of the minimum wage at age 7? It's the effect of the minimum wage at all those previous periods in your life when you were increasing the investments.
Bob,
Yes. Yeah.
we have a question already.
Sure.
Minimum wage. The question's from David Enos. Minimum wage has limited effects on high-cost areas such as New York City, and major effects in rural and other low-cost living areas. Has the analysis compensated for local cost of living?
Yeah, not in an explicit way that was just described, but I'll attend to that in a second. But yes, the short answer is yes. And it's a good answer, and it's a good question, because a lot of times people will, instead of just using the minimum wage in the empirical analysis, they'll use the minimum wage divided by some local wage. So for example, the point is, in Connecticut, the minimum wage of $8 an hour doesn't really affect too many people, where in Mississippi, that minimum wage will affect a lot. So that's the idea. And so we want to incorporate that, and we do. So so the minimum wage will have different effects at different ages in children's life, because as it changes investments, the productivity of those investments differ by each age. And then also how the minimum wage will affect the quantity of investments changes. So, there's two basic insights. And the first is that the analysis should be age specific. So so that means that you should look at children of a specific age, 7, 12, and combining ages might not be the most appropriate thing to do, because of what I said before, is that the effects of investments differ by age. And so when you combine ages, you're combining effects at several ages. And so so we're going to deliver a little bit on that aspect. And then the second, a little bit less obvious insight is that the past minimum wage might affect all current investments. And that's just going to be, that's mostly an interpretation issue. So I'm going to skip pretty quickly through this. But the point of it is that the effect of the minimum wage at, say, age 3 will affect investments at age 3, and then may also affect investments at later ages. So when I'm looking at the effect of the minimum wage at age 3, it combines the effect of minimum wage at age 3 plus how that minimum wage has affected other investments, say at age 6.
Bob, can I ask you a question?
Yeah, sure.
A lot of parents of young children who are near the minimum wage are getting various kinds of government in-kind benefits.
Yeah.
How do you think about that interaction in
Yeah,
this
no,
analysis?
one of the big problems, and thank you, Harold, in this literature is kind of trying to identify who really is affected. So let's take an example of what Harold was talking about. If let's say you get a raise at work because of the minimum wage, that might come at the expense of some decrease in your food stamps, for example. Or if you are encouraged to go to work, you might become ineligible for Medicaid. So there's those types of interactions that I think Harold was talking about. And those are important to see. So that's all embedded in these effects of the minimum wage. So we're thinking again. So what are we thinking of? Is that the primary effect of the minimum wage is to raise income. But as you raise income, as Harold said, it might interact with some transfer payments, food stamps, Medicaid, things like this, that might actually offset some of that increase in income, or might work together. So that's all embedded in what I'm just going to call the reduced form effect. I'm going to try to show you some evidence. Does it affect insurance status and employment? But I think we have looked at food stamps also, because it's clearly it is in the data. So So in the end, we're going to look at our kind of story is that it has a net effect on income and transfers that might affect child health. So I don't know if that's a great answer, but that is the answer. And but it is an important mechanism. There may be some changes in time allocation because of the minimum wage if it does affect employment and hours of work. Of course, see, we're used to giving this to economists. So to say that the minimum wage doesn't have an effect on employment, even it's just a non-starter. You have to just say that it's a possibility when we're discussing it in economics. And it's probably true, but all the evidence, and most of the evidence suggests it doesn't have much of an effect. Okay. And then this greater family income will increase consumption of goods and services, better nutrition, more use of healthcare, and these are beneficial and improve child health. More income can also have kind of other effects through stress and greater residential employment stability, and they can have impacts on child health. And going back to Harold's point, they can interact with the social welfare system, and that the income effects, and then finally, these income effects of the minimum wage, or what I'll call the total kind of resource effects of the minimum wage, might be important at different points in the child's life. So, so that's the story, right? Minimum wages are going to affect the income and other kind of command over resources. Those resources will eventually affect child health, and it might differ depending on when those resources were received. So this goes to Harold's point that he gave me a little credit for raising, is, you know, what's the plausibility of this idea? How much income are we talking about? What's on the table? And so this table is trying to give you an idea about what's the likely effect of $1 increase in the minimum wage on earned income. So what we did is we took data and we looked at people, low educated women, we're just looking at women, and we divided them up by age, or whether they're married or single, and by age and married and single. And then we calculated how much, you know, then we looked at how much they earn, how much hourly, what's their hourly wages, and how many hours do they work. So the idea is, if this group here works about 568 hours a year on average. So low educated women age 18 to 29 with children work about 568 hours a year. So if the minimum wage went up $1, we would think their income would go up about $568 a year. So you can see the kind of numbers on the table over here, and it's somewhere between, say, $500 and $700. So that's what we're kind of talking about. You know, if when later in the presentation I show you results and I say this is the effect of $1 increase in the minimum wage throughout the child's life, what we're talking about is an extra $500 to $700, you know, sometimes more, sometimes less, of income over each year of the child's life. And that's how we're going to think of it. So again, is $500, $700 the average income for women in this sample, low educated women with children, is pretty low. So it's not, you know, for unmarried women, it's quite low. So we're talking about maybe $10,000 or $15,000. So a $700 a year increase isn't trivial in a relative sense. But that's the absolute size of the kind of changes in income that we have in our mind. So the data is one of the most frustrating data sources I've ever worked with. And that's the National Survey of Child's Health. And there's surveys in 2003, 07, 11, and 12. And then there's also a 2016 and 2017 surveys, but they're fundamentally different than these two, because the Census Bureau has taken over the survey now from I forget maybe the NCHS, National Center for Health Statistics, had it prior. It's nationally representative, cross-sectional telephone survey of children up to age 17. One of the interesting or frustrating things is that it creates a sample size of the same size from each state. And so small states are well represented in the data in terms of sample size, but not proportional to their population. We focus on children in low educated families. Again, why do we do that? The minimum wage is only going to affect these families. It doesn't really affect high skilled or high educated families that much. So we want to look where the action is in a sense. We limit the sample to children aged 6 to 17. We do that for a couple of reasons. One of the more important outcomes we're going to look at is missed school days. So it's only measured for children who go to school at age 6. Plus, we think that children's health is that some of the earlier ages that the reporting of children's health is a little less, more volatile and a little less varied than at older ages. So one of the frustrating things about the survey of children's health is the relatively lack of consistency and quality of the measures of child health. There's really, maybe 50 questions about children's health, but it changes. Many of them change from year to survey year. Some of them aren't clear in terms of if they're measuring health or a combination of health and healthcare use. And again, if you go back to our model, we really want to try to focus in on measures of child health, not their healthcare use, because our model, let me just skip back to it. This model is a model of the stock of health. It's your health at age 7. And that health at age 7 is a stock. And that stock is equal to all the investments that occur over a child's life. So you want a measure of health that reflects this cumulative process over a child's life and can kind of conceptually be consistent with this idea of a stock of health. So after much scrutiny of the data, we came up with a few measures. One is just the well-known general health rated by the parent or by the parent, because we don't take children who don't have a parent in the household. And they, is it excellent to poor? We create 2 other indicators, one for excellent or very good health, one for fair or poor health, that are kind of treat the middle category as shifting where the middle category is. So that's just to say excellent or very good health is not equal to 1 minus fair or poor health. They're not exactly the same thing. We have a similar measure of dental health, okay, that the parent gives, again, on the excellent to poor with these binary indicators. So this might sound a little self-serving, but we're really questioning whether we want to put dental health in there. It's not clear that this represents a stock of health and not something of more of an acute indicator that goes up and down. Of course, again, for younger children that are losing their baby teeth and getting the second dentition, I think it's called, we wouldn't want to use those. So yes, Harold.
Another question. One of the standard questions in a lot of surveys is, did you fail to receive some sort of healthcare because of a financial barrier? Were you able to look at any questions that tried to look directly at that channel of this child had a healthcare issue, but we couldn't afford to attend to it or something like that?
Yeah, we're gonna. So let me just skip ahead. So this goes to Harold's talking about the mechanisms, right? What's linking the minimum wage to income to child health, right? These are the mechanisms, right? And one of them, so these are what we're going to say. So the preventive medical and dental visits would be the mechanism linking income to child health. These are the employment related ones, but another one would be, care due to cost. Again, this is one of the variables in the survey. that has changed its wording from year to year. So we didn't use it, but that doesn't. But that's we're gonna probably add this, because even if it changes from year to year, that's just a year effect and not necessarily a real problem. The mean will change by year, but we're gonna have control for year, so that could do it. But we want to add this just for exactly the reason you said. Yes.
And
Harold.
it may be, I mean, given how many of these kids are on Medicaid and CHIP, it may be that we wouldn't see as many, we wouldn't see that mechanism as prominent as it might be for adults. It'd be interesting to see.
Yeah. So, but this brings up another point that again is let me just use this diagram here. Is where is this? What margin of the population is this really relevant for? Does the minimum wage affect income? So for many low-educated families with children, they're out of the labor force. They're not even in the labor market. They're not, 40 or 50% are not even in the game. So because they're not in the labor force, they're on Medicaid, for example, and the minimum wage is really not going to affect them. So it's really trying to pick out that margin of the population that's affected that really is the trouble, or not the trouble, but one of the issues that any empirical analysis has to confront with this. So, okay. And then, so the other question that we think is quite good is we combine these three questions. Do you need medications because of a medical conditions? Do you have greater use of medical care than peers because of a medical problem? Are you less able to engage in things peers do because of a health and condition? So we combine these into what we call an indicator of poor health. And again, I think that reflects our idea of what a stock of health is over time. And then there's chronic conditions versions of this. And then the last outcome we're going to look at is the number of missed school days because of injury and illness, not just for any reason, but because of illness or injury. And then we also look at some mechanisms. So there's the employment mechanisms. Do we see any change in employment? Do they have health insurance coverage? Is their family income below poverty? I might take a step back just to, so the employment question in the survey is pretty bad. It just says, does anyone in the household work? So that's not particularly good. But in terms of the poverty, so you'll see studies that look at the effect of the minimum wage on poverty. And a lot of them show no effect. And that's because it gets back to this problem that I talked about. Basically, these analyses won't have enough power to detect who's in poverty or below the federal poverty level, because again, most of the people here are, when you're below the poverty level, you have a 0 here. It's not, you don't get 100%, you're 0% because you're not working. And the minimum wage is not going to affect a lot of them. So that's just an aside that I think needs to be considered a little more in this literature. So, okay, that's the data. So here's the so we're going to do everything for 2 age groups, 6 to 12 and 13 to 17. The reason we do that, again, is to try to make it age specific, after I just tell you that the conceptual model should be age specific. We don't have enough data to do it by year of age, so we have to make some trade-off, and we combine the ages. So you can see that most of the samples, 72%, are in excellent or good health. For dental health, you see much lower level of health.
By the way, I'm sorry
yes.
to interrupt. There was a question
Sure.
in the chat from Dr. Masal that said, was there a measure of behavioral health in these data?
Yeah, there are. So there is a question, do you have any condition, a medical, or I forget, it combines behavioral, mental, and physical. So there are some questions of behavioral health in here, but they're not, again, we really struggled with trying to formulate one that's kind of consistent with what we call the stock of health variables. So we didn't use anyone specifically to behavioral health. So, but I think, yeah, so some of these questions might have behavioral problems and health problems in them also. So that's the answer. But you could use these data for some, just to study purely behavioral types of issues. Although I don't think the questions are up to the kind of standards that I like, and maybe the gentleman who asked the question would like. Okay, so the age, you can see the ages are there. We have, it's about 40% non-Hispanic white, 16% non-Hispanic Black, and about 38% Hispanic. So that it's probably a little bit, I don't, these aren't mutually exclusive, or they are. So we seem to be overrepresented on the Hispanic population. So the empirical model is just, I'm going to skip. So basically it comes down to a regression of health on the minimum wage, but we measure the minimum wage at different times. So this is the minimum wage during your pregnancy, during the pregnancy period. This is from ages 0 to 5. This is from ages 6 to the current age. And then we have other things in there. And then the effect of the minimum wage, for example, at age 5, measures the productivity of investments at age 5 times how much the minimum wage changes those investments. That's the conceptual model. So we include, this is just regression. We include the state fixed effects, birth year fixed effects. We have child demographics, race, ethnicity, gender, and dummies for each child age and year. So that's kind of a standard regression model. The identification, just we assume that the minimum wage is exogenous. And it's kind of basically a difference in differences research design. We're comparing children in the same state who are exposed to different minimum wages during different periods of their time. So for example, in California, if you were if you're a 6-year-old in 2013 and 2012 or 2003, you were born, right? If you were 6, you were born here in 2006. Here you were born in 1997. And this is the survey year. This is your birth year. And you can see that even in California, during your birth year, the minimum wage that would be relevant would be the 97 minimum wage versus the minimum wage that would be relevant would be 2006. So to the extent that the minimum wage changes during this period, we get a different minimum wage during the pregnancy period for children aged 6 born in California. And that's the basic variation that we're using. So we also run a regression of mechanisms. Here for the mechanisms, we just run the mechanisms, say any health insurance, on just the last period's minimum wage. So we don't look at the whole history of minimum wages for the mechanisms, because we think the mechanism is from the minimum wage in that period to the investment in that period. But I just highlight that it might be misspecified, but because past minimum wages might affect current investments, as I alluded to before. But we're going to assume that's not the case in this model. So we use, since they sampled an equal number of children in each wave, we use the sampling weight that they provide to address that different proportional of being weighted. So that's going to be like weighting by the state population. It makes no difference if we weight by the state population or these sampling weights. Everything we estimate by all ordinary least squares, and we cluster the standard errors by state, because that's the variation in the minimum wage that we're using. Okay, so this is a graph just to show you, well, what's the typical, is there any variation in minimum wages to speak of? You know, again, going back to that story about California, during the pregnancy period, is there really any variation in the minimum wage from 1997 to 2006 for a 6-year-old child? And so these graphs are showing you the kind of typical variation. It's a residual after accounting for state and year effects. So this shows you that, you know, typical kind of variation at ages 0 to 5 in the minimum wage is from, you know, about $1. So this would be a dollar change in the minimum wage, 50-cent increase minus 50-cent decreases. So the typical types of changes in the minimum wages that we're looking at are 50 cents to $1, mostly probably somewhere between 50-cent change to $1 change in the minimum wages. You can see that the older group, there's less variation in the minimum wage for the older sample. And again, this is just because the younger group, remember, is from 2003, 2007, and 2012. Minimum wages have been changing more during this later period than for the older group that might have been, this is from the 1990s. And so the minimum wages have changed more in the early 2000s than in the 1990s. And you can see that reflected in the amount of variation in the minimum wage. So we need some variation. There is variation. How big is it? As I said, it's about 50 cents to $1 of changes. Okay. All right, so let's look at a lot of results. So these are the results for the general health. Here's the dental health. Here's the combined measures of poor health. These are the means. So not to strain your eyes. So I use a little color coding here to help you. So all the red means that these are estimates that the minimum wage has improved child health. So everything in red is indicative of a positive relationship between minimum wage and children's health. The red bolded estimates are the statistically significant ones. And then so you can see that most of the statistically significant estimates here are in the 0 to 5 period, and they make up quite a bit of the total. In this column, we're measuring the sum of all these effects over time. Okay, so during pregnancy, minimum wage, and so forth. So you can see they're just additive, right? So it's 3, 14, 4 is 18, and that's the 18. And then we calculate the standard error of this combined estimate. So I think, again, so if I just, you can stare at it a little more than I can. You can trust me in my summary of it, but I think the red says a lot that most of the estimates are positive in terms of improving health. And then when we look at the cumulative effect here in the last column, we see very, statistically significant effects. And for example, what does this number mean? It means that if I increase the minimum wage $1 throughout the child's life, from the prenatal period to their current age, that they'll be 7 percentage points more likely to be in excellent and very good health than a child that didn't have that $1 increase in minimum wage. Based on a base of 71, that's about a 10% improvement in child health. So again, if you're going back to my story, $1 increase in minimum wage will generate about $500 to $700 a year in extra income. That $500 to $700 every year from prenatal period to current age leads to about a 10% improvement in self-rated health. If we go down here and we look at these combined measures of poor health, it's an 8.3 percentage point decrease in poor health off of a mean of 28. So let's call that a 30% decrease. So a $1, an extra $500 to $700 a year throughout your life leads to a 30% decrease in the probability of being in what we call poor health. And then the chronic condition version of that to have a poor health because of a chronic condition. Again, we have about a 30% decrease in that for a $1 increase throughout the child's life, or about $500 to $700 a year extra income. And then again, finally, it leads to lower about a 33% decrease in the number of missed school days for illness or injury. So there's quite a lot of consistent evidence. And then I think the most appropriate measure to look at is this cumulative effect of the minimum wage over the child's life. Although we do see that the giving the minimum wage at age 0 to 5 seems to have the most important effects, except for dental health here and the pregnancy period, which, to be honest, I just don't have a good story for. But the effects are statistically significant, a consistent pattern of improved health, and between 10 and 30% decreases. So not trivial, but perhaps plausible.
There's another question
Yes.
from Dr. Masal in
Yes.
the chat, which is
Sure.
implicit in the stock of child health is, what is the health of parents and siblings? Is
Yeah.
there an impact if the household includes a parent or sibling with disabilities?
Yeah. So with disabilities, I don't know, but it's a good question because these extra $500 to $700 are also at the disposal of the parents and to use on themselves. So all the siblings would be in here, right? So this is we would say that the siblings would have the same effect because it is a typical child from the family, right? But so just a long and short of this, one of the things we did is we included maternal health in some specifications to see if that's kind of a mediating mechanism, and that's not that wasn't too much of a mediator. But we could look. The point is, we could look at maternal health directly. It does have reports of the maternal health in there to see if it matters. So thank you for that question. Yes.
Yeah, there is some evidence that maternal depression affects answers that women give regarding the health of their children and the behavior of their children. And I wonder, you could imagine that if I'm doing better because of a higher minimum wage, either in reality or my own headspace, I'm giving slightly different answers to some questions about my kids because of that.
Yeah, no, that's why we also, there also is a measure of maternal mental health. And so that's why we included them. I mean, Harold's point is right. And just for, again, graduate students or anybody, if you run a regression of child health on mother health, it's always a very strong positive association. And part of that could be just different reporting biases of the mother, or it could be genetic or real effects. So we were a little worried about that. And so to guard against that, or just to assess that, we did do some analyses when we included maternal health in the regression on the right-hand side, and it really didn't affect these estimates here much. But we could also look directly at that instead of in terms of this mediating exercise. So these are the results that I just kind of summarized for you. And I think the most important ones are these cumulative effects of age 6 to 12. And you can see the effects I told you, 10 to 30% kind of effects for a $500 to $700 a year increase throughout the child's life. And then if you do some correction for the multiple testing bias, all those estimates would still remain statistically significant. Okay. So moving on to the 13 to 17-year-olds, you can see a little less red, okay? So the effects aren't as consistent. But again, if we, these are the mental health outcome, the dental health. So these are dental. If we take out the dental health outcomes, you still see a consistent pattern of improved health across, even for the 13 to 17-year-olds. Again, most of those improvements come at age 0 to 5, okay, with less coming at older ages, although a little bit more in the contemporaneous period. And so here again, although marginally significant, the 8 percentage point increase means if, again, $1 over the child's life, though now up to ages 13 to 17, increases their probability of being reported in good or excellent health of 8 percentage points. Again, the mean is about 70. So that's about a 10% effect, although it's not statistically significant, but marginally so. And then here for these cumulative measures of poor health and for missed school days, we see significant effects of the same magnitudes. Yes, question, Harold?
Ellen Cohen in the chat asked, do changes in minimum wage correlate with changes in other social programs, for example, expansions in CHIP or Medicaid?
So good question, Ellen. Her MPP training is showing. We include actually Medicaid eligibility as a control variable. We include the EITC. I should have mentioned this before when Harold brought up a similar. So we include those in the regression models to control for whether those things are confounding the effect of minimum wages or picking up some other aspects of state policies and not just the minimum wage. So, thanks. It's a good question, and it gives me a chance to highlight that we did consider it. So if I'm going to summarize the results. Again, using the cumulative ones, right? So $1 increase in minimum wages throughout the child's life, again, $500 to $700 a year. It has maybe implausibly large, uncomfortably large, maybe decreases in this combined measure of poor health, and about the same kind of decrease we saw in missed school days of the younger kids. So, it's getting a little big for $500 to $700 a year change, but the standard errors are pretty wide. So it does include a significant amount of other estimates. Other estimates are also suggest generally improved health, except for dental health. And then if we do this home Bumperoni correction, we would still have these statistically significant levels. So, so here, then, if we're going to mechanisms, here's our attempt at looking at mechanisms. 1 second, I just want to clear my screen a little bit. So we looked at, did you have any health insurance coverage? Did you have anybody in the household employed? Were you below the poverty level? Did you have any preventive use of medical care, dental care? And as you see, none of the estimates, all of the estimates are, they're not in bold or statistically significant or meaningful in a material or economic or clinical sense. So we don't, again, the good news here is that we don't find anything in employment. So that's consistent with the minimum wage evidence. We don't find anything on poverty. As I say, you really don't have enough statistical power to do this. The insurance coverage, I'm not quite sure what we'd expect if we find an increase in the minimum wage that doesn't affect employment. It probably shouldn't affect insurance coverage because we don't see any changes in employment that would drive changes in Medicaid or privately insured. So these are really the three employment-related outcomes that we find no evidence of. So that's actually consistent with our argument that it's really working through income. Now, the two kind of investments that we have, we don't see any statistically significant effects on those uses of preventive care. That would be the mechanisms, direct mechanism linking the minimum wage to the child health. It is what it is. Now, these are not the only types of investments that are made. And so I'll just leave it at that. So summarizing them, there's no evidence that there's any change in employment or health insurance. We don't, however, we don't have clear evidence linking the minimum wage to child health, although we don't have really good measures of the investment. Okay. So we do a couple of sensitivity tests because we're anticipating that reviewers will make us do 100 things, 90 which shouldn't have been necessary to do. But we did that. And so one of the things we do is we include 3-year and 6-year leads of the minimum wage. So the idea is that the future minimum wage shouldn't affect current health of the child. So that's just that. And then we look at a higher educated sample that shouldn't be affected. So what I'm showing you here is, here's the estimates of the leads. I've highlighted the ones that are statistically significant. So this is a little bit of a problem, suggestive of a problem, although the 6-year leads aren't significant, and most of the leads aren't significant, but these are, you know, they can't be ignored. And then if I compare the sum of the effects with and without leads, this is for 6 or 12-year-olds. You see, it does make a pretty big difference here on one of our outcomes. So, you know, while, you know, anyway, this is, again, it is what it is. There's some evidence that the research design, there might be, along the lines that Ellen just asked, there might be some unmeasured state-specific trend that is confounding estimates. We can't totally rule it out with this analysis. It doesn't seem to be present when we do 6-year. For 3-year leads, it's not present, but it is present for these outcomes, and it does make a difference on one of these, our conclusions. In terms of the older sample, again, the leads and the lags really have no effects, and it makes no difference to our conclusions. So most of the evidence from this analysis suggests that the research design seems plausible and reasonable, although we do have this one case that merits some caution and caveat. So this is for the high and low educated sample. So I'm just repeating the results here. Lots of red, sometimes significant effects. And then for the high educated sample, we don't see any red. So there's no evidence that there's improvement in health for a high educated sample from the minimum wage. And here for dental health, we see some decreases. For the older sample, here, we do see some effects for on the high educated sample that are here. We note that they're smaller, right? These are smaller than our effects for the sample of we're interested in, and we don't really see much down here. So again, some pretty good evidence that the research design is valid, not slam dunk kind of evidence, but you know, so I don't know if I take my next 2 weeks paycheck and bet everything on it, but I might take a few days and bet on it. All right. So that's the results of the sensitivity test. You know, I think there's some evidence that, while not uniform, I think most of the evidence suggests that it's a plausibly valid design. So our conclusion is that there's substantial evidence that increases in the minimum wage have improved child health. That's noteworthy because higher minimum wages throughout childhood may have significantly and relatively large effects. So this debate over the minimum wage should get past the employment issue and start thinking about other mechanisms. We have a previous paper that shows that the minimum wage is associated with improvements in infant health. Other people have studied that question too. It's that a lot of the effect enters at age 0 and 5. So if you think that might be a particularly critical period, there would be some evidence to support that. And so basically, you know, when we're thinking about the minimum wage in terms of policy, we should think beyond beyond that. So let me stop there and take questions. I have a little more. I have a little lagniappe for you if we have time too. So.
And then I think actually we probably do have time for a little more if you would like, and then we can
Okay.
go and then we can open things up because it's we do have a little bit of time.
Okay, good. So what I wanted to do here is, so we have another project, a similar related project on the effects of the minimum wage on educational achievement. So a different domain, a developmental domain in cognitive domain. But I think it's really important here. So to look at, we're going to go back to that same human capital production function, the way I wrote it here. And I really want to make a point, what I think is an important point that is often ignored. So we have the human capital, or we can think of this as a test score, right? Or the child's health, doesn't matter really, at age T. And that's equal to what the stock of capital was in the previous period times some depreciation plus the investment, right? This is the investment. So the stock of health starts out at a level, some of it depreciates, and then you add an investment to get the current level of health. So if we rearrange a little bit, and so this is the difference in health, or the difference in test scores. And this is a very standard way that, you know, the folks at Chapin Hall would do their analysis. They'll take the difference in test scores of children, or the difference in health. But really the important thing to see here is that difference depends on a level. All right, it depends on the level of investment in the previous period. So it's not the difference in investment, it's the level of investment that occurs in the intervening period, right? And so this is really this is really an important issue that is often ignored. Or if you went, so like if you want to speak stata, for the graduate students who want to speak stata or do stata, you would do, you know, something like xt-reg or put in fixed effects, and it would automatically take the difference of this variable, and that would be making a mistake. All right. And so that's a really, I think that's an important point that's overlooked. So remember, when we talk about investments, these are things, anything, we never measure investments. So we're always using proxy for investments. So what are the typical types of proxies we use? Mother's education, right? Mother's race, her age at birth, or ethnicity. You know, these are all kinds of proxies. So if you notice, all those things would enter even in the difference model, which is a nuance that is always found in the literature and often ignored in the literature, but it's worth some mention. So, but this is what we're gonna do, and we're gonna do it for test scores. And we're going to look at the difference in test scores, and we're going to look at as a change in the investment. Of course, so if we want to do this, so we're going to make investment a function of income, right? And then we're going to make the income, right? So then the regression is the effect of the difference in test scores on the level of income. And then we're going to say, and so this adds to the literature. This is an important model here. This adds to the literature on what's the effect of income on child development, right? Again, a lot of people would think, oh, we know the answer to that. We actually really don't know the answer that well. And there's not that many studies of it in a quasi-experimental context. Now, whether you need that evidence to be persuaded is up to you. But we're going to do this. So now, but this is going to be endogenous, and then we're going to use our minimum wage to instrument for this. And now this is, we're going to use data from the child NLSY to do this study. And here we really, going back to my issue, is how do we find that margin of the population that's affected by the minimum wage? And this is what we do. We interact, we allow the minimum wage to have different effects based on the mother's characteristics, her armed forces qualification test, her education level, her race and ethnicity. And all those things are pretty intuitive, saying that the effect of the minimum wage will differ by these characteristics. And then that'll all vary income along those dimensions. And then we'll have some independent variation in income that's plausibly exogenous due to the minimum wage to identify the effect of the minimum wage on the on child development. So here we have these Peabody Individual Achievement Test scores, children in the NLSY. And so that's the basic regression we run. We do a lot more than that in that regression. All the kinds of controls that you're been used to are in there. And so here's some of the results, and they're quite surprising. But even so, if we look at, again, so here we have enough data to be very age specific. So we're looking at people, the difference in test scores between ages 5 and 7, 7 and 9, 9 and 11. We have the math test score. We have the reading recognition, reading comprehension. I'll note that the standard deviation of these scores is around 10. So even if I just did what a lot of the graduate students would do, go in, run a regression of the change in test scores on income, on mother's earnings, and you can see that these estimates, so this is the effect of $1,000 increase in mother's earnings. The mean for mothers in this sample is $10,000. So this is about a 10% increase in income. And you can see how, even though it's statistically significant, it's a very tiny effect relative to a standard deviation of 10, right? They're just basically very little effect of income. And then the instrumental variables estimate, where we, instead of using the actual income, we use the income that's variation in income generated by variation in minimum wage. Again, so that's affecting a different margin, but you can see that, again, effects are very small and, not statistically significant, but even if we use the confidence intervals, these are very small effects. And that's pretty much the punchline for at every age and every test score, that there's very little evidence of that maternal earnings or income affects the test scores of children at these ages. So, I was very surprised at this. I think this is a pretty powerful research design. In some sense, it's better than what we were doing in the child's health one, because in this data, we actually have income. We can show that minimum wages, in fact, does change mother's earnings. We can exploit the variation in that relationship that's intuitive, because different mothers have different levels of education, and we'll call it some measure of ability or education combined will be affected differentially. So we generate some really good plausible variation in income using the minimum wage. And but even if you just did the naive, you would find no effect of income on these test scores. And even when you instrument thinking that might not be the right way to go, we find no evidence. So that was a little bit of extra for you to show you another project we're doing related to this in the same domain of child development. So I'll definitely end there then. So.
Well, thanks. That's really interesting. I mean,
yeah.
I wish the finding were different, because
yeah.
Because it would give us an avenue to help kids that,
yeah.
But this could. But
well,
I think that's really interesting.
Let me comment on that, Harold. So if you're comparing the results, I mean, let's just take them for as they are. We seem to find something on children's health. And and children's health is really mostly influenced by the family and medical care, and not the community or in the environment. Where on test scores, right, it's really the schools that do all the heavy lifting for children's cognitive achievement and ability. So maybe in that sense that schools are a great equalizer. And now, of course, we're looking at small changes in income of $1,000. If you tell me my daughter, goes to, a private school in Chicago, money matters. I do think money and income matter. But on that type of extra $500,000, schools might be a quite important equalizer, where for health, there's no similar institution in the community that intervenes as much. So that would be one take on it, my way.
Questions from the audience? Now, I'll just ask you a couple questions while
Okay.
just as a one. Well, I mean, so earned income tax credit is
Yeah.
a very large program that's benefiting young parents. I wonder if there's a way to say, what do we think the health impact is of the EITC based on these types of analyses?
Yeah, so it's a great question. So again, I'll kind of recap. So people have done it for infant health, right? They've looked at the effect of the earned income on infant health, and they find beneficial effects like we found of the minimum wage. So that's a similar finding. And then there is a paper, very well-known paper by Gordon Dahl and Lance Lochner, that uses these data, the same data that we use, and the exact same. So they use the same data, and if you look at their paper and their OLS estimates, they look a lot like ours. Okay, and then instead of instrumenting for income with the minimum wage, they replace it with the EITC, as which you obviously saw the analogy. Now they get different results here, but they do something they don't look at this. They look at YT minus 1, YT minus YT minus 1. So they do what we think is the wrong thing to do, right? Instead of looking at the level of income, they look at the change of income. And just to make this point, because I really think it's an underappreciated point, think about what this says. This says if the parents' income didn't change, the kids' test scores wouldn't change between ages 8 and 7. But that's not true. So let's say if you're at the University of Chicago, your income's not going to change this year, right? Because we're not getting any, but I'm going to still take income out of my income this year and invest it in my child. So even though my income didn't change, I expect my daughter's test scores to increase. And that really drives to me the point home that this is the wrong way to proceed, just intuitively and conceptually. And so when we don't proceed that way, and you'll see we don't get big effects. But if you do proceed this way, you'll see that we can replicate that or get close to what the EITC findings get. And so, but our point is that that's really not the right answer. So 2 points. One is it's completely analogous to the EITC. And our results on child health are, in terms of infants, perfectly analogous. Nobody's done it with child health, but we have. But then when you look at the educational estimates, we differ from the EITC, but we think it's really because we did it right. So
yeah. But the other thing I was thinking about when I was thinking about mechanisms through which this might happen is one of the lives of people who are living near the economic waterline are precarious, and families experience evictions. They experience the stress of not being able to pay bills, of having to, all kinds of, they're buffeted by circumstances that
Yeah.
that income can buffer. And I wonder if you looked at something about the family circumstances of over time, whether there would be a way, and I'm sure this is the right data set for it, but if there's a way to show with a higher minimum wage, here's some stressful family events that are less likely to happen because the minimum wage has been bumped up a bit, and whether we have any data that might speak to that.
Yeah, I mean, the weakness of this paper, there's a couple, but one of them is that we just don't, we don't have this, we don't have the linkage, the mechanism. So I think some have already came up, the mental health, right? I think that from stress and financial worries, the residential mobility, the evictions, all this kind of stuff. We need to, to the extent that that's in the data, I don't know if it's in the data, but those are good ideas to link, because it is these types of things that can really undo families. And to the extent that we can see the minimum wage buffering them from those types of things, it builds a stronger, linkage to our main results. So yeah, I mean, I think that's a good idea. It is a really unwieldy survey, full of many questions. It's just the worst designed survey. I'm one of the worst. I have great hopes for census taking it over, and they have improved it going forward in 2016, 2017. We just can't use it because we don't have enough variation of minimum wage during that short period to do.
One practical follow-up question. So so suppose that the Biden transition team emailed you today and said, we want to ratchet up the survey research game as it relates to child health. And, we just saw your presentation and here's $100 million to go out and collect some data that over time would be valuable. Yeah. How would you spend that money?
All on biomarkers. I'd be, drawing blood, measuring, giving, validated assessment instruments, and those types of measures, and not these general self-rated health, do you use more care than peers. Mm-hmm. These kind of, really kind of try to get objective measures, and some of the clinicians who are listening might have other ideas, but that's really where I'd focus on, really clear measures of child health that are also sensitive to kind of amenable to interventions.
So sort of NHANES.
Yeah,
sort of
exactly.
Like souped up NHANES with a pediatric component.
Right, and NHANES would be great. That's exactly right. So NHANES is great, but what makes NHANES not great sometimes are the small sample sizes. And of course, to use it for this type of analysis, but you've given me a good idea. I think we should move to NHANES. You just got to get the confidential access to the geography, but that's we had to do that anyway here. So, but that kind of NHANES stuff, but broader with exactly, good point. So,
but one of my own pet peeves is so many data sets mask the state identifiers.
Yeah,
and I really don't know that that's necessary in terms of protecting respondents. And it basically kneecaps the ability to do a lot of policy analysis that needs to be done. And I wonder if that's something that could be revisited across data sets, because so many of them, or to get the state identifier, you have to do a whole OJ trial, with which privileges people at elite institutions to do the work.
Yeah, and it's time consuming, and a lot of times you have to do the work at a facility, a secure facility. So, either at the Federal Reserve Bank here, where we have the Data Research Center, or down at NCHS and in Hyattsville. But it does put strong impediments in for, I think, the cost benefit. Like you said, it's very hard to think about identifying someone in a state when just I know what state they live in, and it should be an easier process. But and that's exactly right.
So I think we're coming up on the witching hour. Okay. Anybody with a last question before I send everyone on their way? There's something that just popped up in the Q&A. Stephanie Hong, after looking at your results on mother's income on child education outcomes, I was wondering, when we think about the effects of social safety net programs such as SNAP on child education outcomes, do you think the maternal stress pathway, i.e. lower maternal stress due to receiving benefits, leads to better interactions with the child, could be a more plausible explanation than the income effects, i.e. increase in income leads to greater parental investment?
Yeah, I mean, I think that's a really, good way to frame it. Ideally, we could unpack that, right? Because we could look at, along the lines we've been talking about today, does the minimum wage, so maternal stress, it might show up in terms of the survey that we have in mental health and in the responses to mental health questions. But that type of stress, I think, is really an important aspect of how mothers can, respond and invest. That's an investment, right? I would just call it a quality of investment. When there's a stressed out caregiver, that quality of the care is lower than when there's not a stressed out caregiver. So, but that ideally we would unpack that. So again, you guys have all zeroed in on the weakness of this analysis, and we have a result that we haven't unpacked, and that's the way it should be.
Well, thanks, Bob. Yeah, Stephanie asked such a great question. I mean, there's this expression, love is patient and kind. It's a little harder to be patient and kind when you're financially stressed. So why don't we give our speaker a warm round of internet applause, and thank you, Bob, so much for giving a great presentation today. Keith, is there anything else I should do as I close out?
No, thank you, Bob. We appreciate you being here today, and thank you everyone for watching.
Thank you. It's my pleasure. I really appreciate the comments and attention. Thanks. Bye.
All right. Bye-bye.
Bye-bye, everybody.